everyone, and welcome to another edition of Contagion. My name is John Parkinson, and I'm the senior editor. Joining us today is Dr. Aakriti Gupta. She is cardiologist at Columbia University's Irving Medical Center. Thank you, doctor, for being able to join us today.
Hi, very nice to meet you. Thanks for the opportunity to be on this today.
Absolutely. Let's jump right into the topic. For those not familiar with your research, can you provide an overview of your study and your findings?
Absolutely. Working in a New York City hospital, I was involved in taking care of patients with COVID-19 very early on. And basically, people who get hospitalized have a spectrum of manifestations that they can present with, which are besides the lung involvement that we already know about. So we think about COVID-19, which is caused by the SARS-CoV-2 virus, which is a severe acute respiratory syndrome. Two, because we have had the SARS epidemic in 2003, and that intuitively makes us think respiratory, which is true for the majority of COVID patients who do not make it to the hospital, presumably. But the ones who do make it to the hospital are very sick and can present with multiple system organ involvement that we observed early on, and were able to do a deep dive into the literature and take all the insights we got from our clinical experience, and we're able to put that together in the review that got published in Nature Medicine. We assembled a team of interdisciplinary experts who were at the front lines taking care of patients, and also are experts in their fields. And we were able to get a lot of very deep knowledge about this. So what I would summarize this to be is that people who present with COVID-19 can have very commonly acute kidney injury, which was seen in at least 50% of patients who were presenting to the intensive care unit. And 1 in 3 patients who were presenting to the intensive care unit were also requiring dialysis, which is a very high proportion for any severe illness that we know of. Even what is commonly coded as severe influenza, this was even more than that. Besides that, we find troponins to be significantly elevated in these patients, which is a marker of myocardial injury. And then neurological involvement was being noticed a lot. People were presenting with strokes, and there were these common symptoms of loss of taste and smell, all of that. So multiple organs. In fact, diarrhea was a very common presentation that has been reported from a lot of countries. It's even a recent paper in JAMA suggested that even after COVID, for a prolonged period, people can have diarrhea. So all of these multiple organs that we don't traditionally think of when we think of acute respiratory virus. But that's what we wanted to bring to the forefront, that we should rule out all this multi-organ involvement in everybody who gets hospitalized in particular.
So you should look at it a little bit more holistically as opposed to being just a respiratory virus. Is that correct?
Correct. Over the experience that we gathered while taking care of these patients, we developed protocols of what we thought would be the best thing to do. And one example is once we started noticing so much kidney injury, in the emergency department, we started quantifying urine protein, which is we don't do that normally. Normally, we would just do a urine dipstick, which tells us if there is protein in the urine or not. But we quantified the urine because proteinuria was being seen very commonly. 87% of patients who were admitted to the Columbia ICU had proteinuria. So that was a marker of severe disease and can help triage patients at the time of admission. Several similar protocols we had developed for almost every organ system.
And can you talk a little bit about the protocols for the various elements, the neurological, the cardiovascular, and the renal?
Sure, absolutely. So one of the things that were, was commonly observed and has been widely reported on from multiple countries and institutions is a very prothrombotic state that these patients have, which means that they're clotting in several vascular beds, whether it be arterial or venous, which can present as deep vein thrombosis, pulmonary embolism, myocardial infarction, strokes, One common thing was repetitive clotting of the catheters, which could be the arterial catheters or venous catheters, even the ones we're using for dialysis. So that prompted us to think of how aggressive we should go in terms of preventing clotting. So we did have protocols where for people who were requiring new dialysis and had a dialysis catheter, we would give them some anticoagulation, which is a blood thinner, so that their catheter doesn't keep clotting and we don't have to keep changing it every time. Similarly, we commonly basically do prophylactic anticoagulation, which means preventing blood clotting in everybody who gets admitted. But for patients with COVID, we also launched a randomized control trial to investigate if a higher dose of the medication for blood thinner, higher dose anticoagulant for prophylaxis is better or not than traditional anticoagulation. So that's one of the few things. From the terms of cardiological involvement, we had to modify a lot of our protocols. Normally, when patients present with something that we call ST elevation myocardial infarction, which is a serious kind of a heart attack, we normally would, activate the catheterization laboratory and take the patient right to the cath lab to open up the blockage. But in times of COVID, we had to modify protocols and had to think about every patient in an individualistic way, and there was no definite protocol there because we wanted to minimize exposure. But one thing we are doing in everyone with COVID is checking troponins, which is a marker of myocardial injury, which is not normally done, but because in these patients, we want to triage them, we want to know how sick they are at the time of admission, we would check troponins on everybody. The other common thing that we did for every patient is something that we said was we called COVID labs. So COVID labs basically means we would screen for multiple organ involvement and inflammation right at the time of admission. So when they presented to the emergency room, we checked for their blood work, in which the normal labs we would do would include their blood counts and their chemistries. But now we were also checking for all of these markers of inflammation, like the ESR, C-reactive protein, D-dimer, fibrinogen, lactate dehydrogenase, and interleukin-6, one of the other markers which remdesivir works against. So those were the kind of things we were doing, particularly for COVID, that was not normal routine before that.
Wow, that's very interesting that you had, in fact, a COVID-based panels and screenings for patients that you were seeing that was different type of protocol from what you would normally see for patients coming in.